For the second part of the lecture, I will discuss hyperthyroidism and antithyroid drugs. On this slide, you can see the causes of hyperthyroidism. Firstly, we have Jod-based phenomenon, which I introduced in the previous video as iodine-induced hyperthyroidism due to impaired autoregulation. Next, we have amiodarone-induced thyrotoxicosis. Amiodarone is one of the drugs that decrease peripheral conversion of T4 to T3 and may cause hypothyroidism. However, there are about 3% of patients on amiodarone who present with hyperthyroidism instead. Because amiodarone contains iodine, it can induce hyperthyroidism. So AIT is actually a form of Jod-based phenomenon. Thirdly, we have Graves' disease, which is the most common cause of hyperthyroidism. Graves' disease is an autoimmune disease wherein patients develop antibodies against TSH receptors, but instead of attacking the receptors, the antibodies are stimulatory in nature, activating the receptors and increasing the synthesis of thyroid hormones. There are several factors that increase the development of these TSH receptor antibodies. These are genetics, postpartum state, cigarette smoking, and stress. In addition to hyperthyroidism, Graves' disease can lead to complications such as toxic diffuse goiter, ophthalmopathy, and rarely dermopathy. When we say toxic, we are talking about a disturbance in thyroid function, usually hyperthyroidism. In Graves' disease, we have toxic diffuse goiter. In Plummer disease, we have toxic multinodular goiter. If the goiter is caused by a single toxic nodule, the nodule can be surgically removed. But with toxic multinodular goiter, we give antithyroid drugs followed by subtotal thyroidectomy. Subacute thyroiditis is precipitated by a viral infection that destroys the thyroid parenchyma, leading to a release of stored thyroid hormones, causing a transient hyperthyroidism. Since the underlying cause is inflammation, subacute thyroiditis responds to corticosteroids such as prednisone. Pregnancy can also cause transient hyperthyroidism because TSH and HCG are structurally similar. During the first trimester, there is a high level of HCG, which binds to TSH receptors, stimulating the thyroid gland. Pregnant patients may present with gestational transient thyrotoxicosis, which is associated with hyperemesis gravidarum, and this subsides after the HCG level declines. Lastly, TSH-secreting pituitary adenoma is a rare cause of hyperthyroidism which resolves after surgical removal of the adenoma. Sometimes hyperthyroidism and thyrotoxicosis are used interchangeably, but they are not the same. Hyperthyroidism is characterized by the increased synthesis and secretion of thyroid hormones, whereas thyrotoxicosis is the clinical syndrome of excess circulating thyroid hormones. So these are the clinical manifestations of thyrotoxicosis, essentially the opposite of those in hypothyroidism, except for a few that may be present in both hypo and hyperthyroidism, such as hair loss, hypoventilation, and anemia. More specific to Graves' disease are the retraction of upper eyelids and bulging eyes, or exophthalmos. I'm showing this picture again because here are the antithyroid drugs inhibiting the different steps of thyroid hormone synthesis. We have anions inhibiting the iodide transport, iodides and thioamides inhibiting organification, and iodides inhibiting proteolysis and release of thyroid hormones. Finally, we have beta blockers, not a major antithyroid drug group, but important adjunct in the management of thyrotoxicosis. Of the beta blockers, it is propranolol that can inhibit peripheral conversion of T4 to T3. Earlier, we compared the pharmacokinetics of T3 and T4. Now we compare the pharmacokinetics of the two major antithyroid drugs, specifically the thioamides, methimazole and propylthiouracil, which I will refer to henceforth as PTU. In terms of potency, methimazole is 10 times more potent, making it the drug of choice in most cases of hyperthyroidism. Absorption of methimazole is complete as compared to 50 to 80% bioavailability of PTU. Both MMI and PTU are FDA pregnancy category D with risk of fetal hypothyroidism. However, PTU, being highly protein bound, is an advantage during the first trimester of pregnancy because being bound to maternal protein means it's less likely to transfer across the placenta and affect the fetus. Methimazole is known to cause congenital malformations, so its use is avoided during organogenesis. Both methimazole and PTU have a short plasma half-life, but because they are concentrated by the thyroid gland, the duration of action is longer. Methimazole at 30 mg once a day exerts an antithyroid effect for more than 24 hours, which allows for once daily administration, whereas PTU at 100 mg can inhibit organification by 60% for up to 7 hours, which means PTU should be given every 6 to 8 hours. Thiamides inhibit the major steps catalyzed by thyroid peroxidase in the thyroid hormone synthesis. Both drugs inhibit oxidation, organification, and coupling. PTU has an additional action of inhibiting peripheral conversion of T4 to T3, but because it is inferior in terms of potency, duration, and safety, it's reserved for special cases such as first trimester of pregnancy, thyroid storm, and non-serious allergic reactions to methimazole. Thiamides are used as primary treatment in hyperthyroidism, most commonly due to Graves' disease, and in thyroid storm. Thiamides are also used as adjunct to thyroid surgery for toxic multinodular goiter. I also want to point out that I specified the type of amiodarone-induced thyrotoxicosis. This is because there are two types. First type is iodine-induced, which is a form of jod-based phenomenon, and this type 1 responds to thiamides. The second type is inflammatory induced, so it will respond to corticosteroids such as prednisone. On your upper right, you can see that both drugs are available in tablet forms. For methimazole, it is available in strands of 5, 10, 20, and 30 mg, whereas for PTU, it's available in strands of 50 mg. Antithyroid drug therapy usually starts with divided doses, even with methimazole. So we can give methimazole 5 mg one tablet every 8 hours to achieve 15 mg per day for 4 to 8 weeks. The initial dosing can be higher or lower depending on the patient's baseline level of FT4. Once the patient becomes euthyroid, the dose of methimazole can be gradually reduced to 5 mg once daily. As for PTU, the initial dosing is 100 to 150 mg every 6 to 8 hours until patient is euthyroid. Since PTU is available only in 50 mg tablet, we can give 2 tablets every 8 hours. Once the patient becomes euthyroid, PTU can be gradually reduced to 50 to 150 mg per day, which means 1 tablet every 8 hours. The best clinical guide to remission is reduction in the size of goiter if present. And of course, before any dose adjustment, there should be monitoring of thyroid function tests. The most common adverse reaction to thiamides is maculopapular pruritic rash, which we can treat with an H1 receptor blocker. There are other adverse reactions, but they are quite rare. More importantly, I want you to remember the serious adverse drug reactions, because PTU has a black box warning of severe hepatitis, which provides another important reason for choosing methimazole for most cases of hyperthyroidism. Methimazole is not only more potent than PTU, but also relatively safer for the liver and more suitable because of its once daily dosing that increases the patient's compliance. However, methimazole at a higher daily dose may cause agranulocytosis, which can be life-threatening but is rapidly reversible when the drug is discontinued. You may also give granulocyte colony-stimulating factor to hasten the recovery of granulocytes. In case of serious adverse reactions to one thioamide, you do not switch to the other because the cross-sensitivity between the two is 50%. You will need to explore other treatment options. I mentioned in the previous slides that PTU is the drug of choice for first trimester of pregnancy because it is highly protein bound, protecting the baby from teratogenic effects of methimazole, which include aplasia cutis and esophageal atresia. After the first trimester, the mother may switch to methimazole because PTU is highly hepatotoxic, so chronic use will endanger the mother. Anions were one of the earlier drugs in the treatment of hyperthyroidism. These include perchlorate, pertechnetate, and thiocyanate. They block the iodide uptake by competing with the sodium iodide importer. The major use of potassium perchlorate is amiodarone-induced hyperthyroidism type 1, but because of aplastic anemia, it's rarely used nowadays. Formulations of iodides include saturated solution of potassium iodide, SSKI, and Lugol's solution, which contains iodine and potassium iodide. Iodides are not used alone and not used for long. To decrease size and vascularity of hyperplastic gland, SSKI can be given 5 drops twice daily for 2 weeks prior to surgery. By inhibiting hormone release, iodides provide rapid relief of symptoms in thyroid storm. By now, you should already be familiar with Wolff-Chaikoff effect and Jod-Basedow phenomenon. Iodides are contraindicated in pregnancy because Wolff-Chaikoff effect may persist and induce fetal goiter. Jod-Basedow phenomenon is pathologic because there is no negative feedback. It occurs in patients with Graves' disease and patients with amiodarone-induced thyrotoxicosis type 1. Adverse reactions to the iodides include rash, conjunctivitis, rhinorrhea, swollen salivary glands, mouth ulcers, and metallic taste. So the solutions are best taken with food or diluted with fluids. Iodine 131 or radioactive iodine is available as capsule or solution. It is rapidly absorbed by the GIT and concentrated by the thyroid. It emits beta rays that begin to destroy the thyroid parenchyma after 6 to 12 weeks, with maximum effect at 3 to 6 months. The advantages of RAI include effectiveness, easy administration, absence of pain, and low cost, although the last factor is debatable in our country. Patients should prepare by being on iodine-free diet for 7 days to maximize RAI uptake and prevent dietary iodine from competing with RAI. Ideally, patients with severe hyperthyroidism or cardiac patients should be euthyroid before RAI because RAI can cause transient thyrotoxicosis due to the leakage of stored hormones after destruction of thyroid parenchyma. Pre-treatment with methimazole to achieve euthyroid state may be done to prevent the progression of thyrotoxicosis to complications. Although RAI permanently cures hyperthyroidism, as many as 80% of patients will develop hypothyroidism, which in their case requires lifelong levothyroxine replacement therapy. RAI is not for all patients. It's absolutely contraindicated in pregnancy and lactation because it can cause irreversible damage to the baby's thyroid. After RAI, you also need to prevent radiation toxicity to the people around you by staying away from them for up to 1 week and away from pregnant women and children up to 3 weeks. RAI is also not given in severe cases of Graves' ophthalmopathy because there is a 15 to 20% risk of aggravating the eye disease. On this slide, I created a table with references from Katsuo and the American Thyroid Association guidelines. In this table, you can see how patients choose among the 3 primary methods for control of hyperthyroidism. With antithyroid drug therapy, our mainstay is methimazole. Advantages of choosing oral methimazole include the possibility of remission after 1 to 2 years of treatment, as well as avoidance of radiation, surgery, and lifelong thyroid hormone replacement. However, there could be adverse drug reactions during the treatment and a high risk of relapse after discontinuing the drug. especially in smokers, those with persistently elevated TSH receptor antibodies, and those with large goiters. With RAI and surgery, patients are assured of a definitive control of hyperthyroidism. Control is more rapidly seen with surgery than with RAI, but of course, not many patients would choose surgery due to intraoperative and postoperative surgical risk. Both RAI and surgery come with the disadvantage of developing permanent hypothyroidism, which would require the patient to be on lifelong thyroid hormone replacement. RAI also comes with exposure to radiation, not just for the patient, but for the people around them. For female patients, RAI is contraindicated in pregnancy, and those who want to become pregnant have after RAI must wait at least 6 months to minimize risk of radiation to the pregnancy. Again, these are just patient considerations, not including clinical indications. Beta blockers are not major antithyroid drugs, but they're considered as effective adjuncts in the acute management of thyrotoxicosis and thyroid storm. Specifically, beta blockers without intrinsic sympathomimetic activity, such as atenolol, metoprolol, and propranolol, can be used to control the tachycardia, hypertension, and atrial fibrillation. Propranolol can be given at 20 to 40 mg every 6 hours. Among the beta blockers, only propranolol at a high dose of 160 mg per day can inhibit peripheral conversion of T4 to T3. Beta blockers can cause bronchospasm and are thus contraindicated in bronchial asthma. So the alternative for control of tachycardia would be diltiazem, which is a calcium channel blocker. Glucocorticoids are anti-inflammatory agents used to manage severe thyroiditis that is induced by amiodarone or viral infection. It may also be given to relieve symptoms of Graves' ophthalmopathy and manage severe metabolic stress in neonatal Graves' disease. As for Graves' dermopathy, a topical steroid such as triamcinolone is applied to the affected area and covered with occlusive dressing. In thyroid storm, IV hydrocortisone may be added not just to protect the patient against shock, but also to reduce thyroid hormone levels by peripheral inhibition. I would like to dedicate the next few slides on special problems and special populations. Ophthalmopathy is a complication of Graves' disease. Cigarette smoking is one of the major factors that increase the development of TSH receptor antibodies. Therefore, smoking cessation is necessary to prevent the progression of this eye disease. For relief of severe proptosis, acute pain, and swelling, we may give oral prednisone 60 to 100 mg daily for a week, then taper. Or if available, we may give IV teprotumumab, a monoclonal antibody against insulin-like growth factor receptor type 1, or IGF-1R. This receptor stimulates TSH receptors in the orbital fibrocytes, so this drug will decrease the stimulation. We should also advise non-drug measures such as elevation of head to diminish periorbital edema and the use of artificial tears to relieve corneal drying due to bulging of eyes. If all these measures fail to improve the acute inflammatory reaction, irradiation of posterior orbit may be done. Most importantly, we need to treat the underlying thyroid disease with radioactive iodine or total thyroidectomy because RAI has a risk of aggravating the eye disease. Complications may require more surgeries such as decompression of the orbit as well as eyelid or eye muscle surgery. So we should do our best to prevent complications. If myxedema, is severe hypothyroidism, then thyroid storm is severe hyperthyroidism. Likewise, it's a medical emergency. Propranolol is given to control severe cardiovascular manifestations. Our thiamide of choice is PTU because it has an added advantage of inhibiting peripheral conversion, which brings down the thyroid hormone levels more rapidly. But once the patient is stabilized, we need to switch to methimazole for safety. Potassium iodide is given after PTU to inhibit release of thyroid hormones. It is not given before PTU because it may induce synthesis of thyroid hormones. Finally, hydrocortisone may be added to protect against shock. Most of these drugs rapidly decrease the serum levels of T3 by inhibiting the peripheral deiodination of T4. Again, iodide should be excluded if thyroid storm was induced by iodine, as in Jod-Basedow phenomenon. Neonatal Graves' disease is primarily caused by maternal Graves' disease. The maternal TSH receptor antibodies cross through the placenta into the fetus. The disease is self-limited and subsides after the antibodies are cleared from the circulation. But because of severe metabolic stress, both supportive therapy and drug measures are necessary. As the clinical picture improves, these medications are gradually reduced and discontinued by 6 to 12 weeks. Some of the things on this slide are somewhat familiar by now. We give levothyroxine for hypothyroidism, PTU for hyperthyroidism in the first trimester, then switch to methimazole for the rest of pregnancy. Be it treatment of hyper or hypothyroidism, our TSH goals are the same. Pregnant women have lower TSH because they have higher thyroid hormone requirements. We would like the maternal TSH to be in the lower half of normal range because we want the mother to have adequate thyroid hormones to pass on to her baby for their normal growth and development. In case of severe hyperthyroidism that is not responsive to antithyroid drugs, the safest time to perform surgery would be the latter portion of second trimester. But this is not without risk. There is still a 4 to 5% risk of preterm labor. Nevertheless, the risk of preterm labor is much higher in the third trimester, whereas the risk of fetal loss is high in the first trimester. Here are some of the major takeaways from this lecture. I hope you enjoyed learning about thyroid pharmacology. Thank you for listening. If you have any questions, please email me.